Today I'm going to talk about a very common, a very important, and very dangerous topic, and that's hypertensive emergencies. Yes, I'm putting an emphasis on it because it is the most important and most common risk factor that you come across in a patient presenting to you in emergency department. Some patients might be having complications due to hypertensive emergencies. Let's talk about some hypertensive emergencies. So what is hypertension? It is increase in systolic and diastolic blood pressure. It is said that hypertension is divided in two parts. It's primary, that's essential hypertension, or secondary hypertension. Primary hypertension most of the time is without any cause, and that covers the most part of the causes of hypertension, around more than 90%. And the rest of the percentage is taken up by the secondary hypertension that has a cause for hypertension. For example, renal artery stenosis, pheochromocytomas, and much more. But for 95%, 95%, the cause of hypertension is not known. So, systolic blood pressure of more than 150, more than 140. Diastolic blood pressure of more than 90. Asymptomatic. Why is I've put an emphasis on asymptomatic? Blood pressure most of the time, hypertension most of the time is asymptomatic. There are no significant or classical signs of hypertension. Yes, there can be a signs of complications that are due to hypertensive emergencies or hypertension, chronic hypertension. But hypertension itself does not cause most of the time any symptoms. There are misconceptions, lightheadedness or dizziness or headache can be due to hypertension. It can be, but not all the time. So hypertension most of the time is asymptomatic, and that is why it is known as silent killer. It won't show up, it won't give you any signs and symptoms, but it can kill you inside. Cardiovascular and renal diseases. Hypertension is most common cause of cerebral, cardiac, and renal impairment. This is the most common risk factor that has some fatal outcomes in these main organ system. Although hypertension can cause much more diseases or can be part of many more diseases, but the main organs, the life-threatening organs, for example, heart, renal system, and cerebral system, can be affected by hypertension. There are two types of hypertensive emergencies. One, hypertensive emergency, and next is hypertensive urgency. Well, there's a slight difference in the definition of both of them. Both of them show a high blood pressure, but it is said if a patient presents to you with hypertensive urgency, it is said that hypertensive urgency is more than blood pressure of more than 130 without any end organ damage or any symptoms. On the other hand, hypertensive emergency is increased blood pressure with signs of end organ damage. Why is this end organ damage happened? I'll explain further in the next slides under the section of pathophysiology. But for now, take-home point is hypertensive urgency is symptoms or without symptoms, and hypertensive emergency is with symptoms and end organ damage. So, as you can see in this slide, the things that are most affected by the hypertensive emergencies or hypertension itself: brain, cardiac, and renal system. This is heart and renal system. most common cause of renal failure or heart failure is hypertension. So this is hypertensive emergency, hypertensive crisis. Hypertensive emergency and urgency are both called hypertensive crisis. But again, urgency is without any symptoms or an organ damage. While on the other hand, emergency is with symptoms and with an organ failure. And organ damage, hypertensive emergency, not asymptomatic. So that means the patient is symptomatic. Diastolic blood pressure of more than 130. It is very, very important. Time-sensitive management, reduce 25% of mean arterial pressure within 30 to 60 minutes. Why is just 25% is the choice of treatment in patients with hypertensive emergencies? Because with a rapid reduction of blood pressure, there are chances of hypoperfusion to the brain. When there's hypoperfusion, especially to the watershed areas are those areas that have been supplied by the terminal vessels or have some minimum amount of blood supply. So with hypoperfusion to the watershed areas, to the brain, there are chances the patient might suffer from a stroke or a cerebrovascular accident. So it is not always important to reduce the blood pressure suddenly within minutes from 180, for example, or 130 to 120/80. This can cause hypoperfusion, cerebral hypoperfusion, and can eventually lead to stroke and further fatal outcomes. So in hypertensive emergency, you have to treat the hypertension, but within limits. You don't have to be aggressive in treatment, and lowering pressures too much down might cause cerebral hypoperfusion. So moving on to pathophysiology of hypertensive emergency. Again, what is hypertensive emergency? Is increase in diastolic blood pressure of 130 with an organ damage. What happens in acute emergency and acute hypertensive emergency? There is abrupt increase in arterial pressure. There are changes in the at the cellular level, organ level, and environmental changes can help or can propagate hypertensive emergencies and problems and complications. What happens is there is fibrinoid necrosis inside the vessel. With fibrinoid necrosis, increased chances of ischemia. With ischemia, there is end organ damage due to decreased blood supply. So as you can see, the vessel, hypertensive emergency, circulating vasoconstrictors, abrupt increase in systemic vascular resistance, and abrupt increase in blood pressure. With increase in systemic vascular resistance, there is increased resistance to flow of the blood. With increased resistance to flow, the heart or the capillaries need more force to ejaculate the blood, which causes hypertension, which causes increased pressure. So with increased pressure, there is increased endothelial damage. With endothelial damage, there are chances of capillary leakage due to pro-inflammatory or inflammatory mediators to activate. With activation, there is increased chances of accumulation of fibrin and fibrinogen clots. With clots that are covered with fat or atherosclerotic plaques lead to ischemia. With ischemia, eventually there is loss of outer regulatory functions and an organ ischemia. It is the most common cause. Atherosclerosis is the most common cause in the patients who present to you with high blood pressure or coronary artery disease. Why is this so? Because of decreased blood supply. In hypertensive emergency, there is abrupt increase in systemic vascular resistance. With this, there is increased chances of endothelial damage and loss of outer regulatory functions. At times, outer regulatory function itself, with chronic hypertension, outer regulatory functions are set to a higher point with chronic hypertension. And that is why with sudden decrease in blood pressure in patients with hypertensive emergencies can lead to hypoperfusion, because the outer regulatory functions, or in simple words, the threshold in a patient with chronic hypertension is changed due to change in outer regulatory functions. With this change in outer regulatory functions, rapidly decreasing blood pressure can cause hypoperfusion. So that's the key point. What are the red flags for hypertensive emergencies? Working in an emergency department, you have to think as an emergency physician. High blood pressure without symptoms should not be a problem for any physician. But high blood pressure with red flags is a problem. While working in emergencies, patients who present to you with high blood pressure, these are the most common red flag signs you could appreciate or you can come across in a patient in emergency department. Headache with CNS problems. Headache. It is common presentation in patients with hypertensive emergency. It has a wide variety of differential diagnosis. For example, patient comes to you with headache, hypertension, hypertensive emergency, and with headache. Think of intracranial hemorrhage. Think of a stroke. Patient presents to you with high blood pressure and neck pain. Think of vertebral artery aneurysm or dissection. Look for any focal neurology. Look for any deficit. This is the red flag. Headache with neck pain, as I mentioned before. Vertebral artery problems, vertebral artery dissection. Hypertension, headache, and neck problem. Red flag sign, think of vertebral artery dissection. Chest pain, most common presentation. When you come across a patient with high blood pressure, hypertensive emergency, and with chest pain, you should think of aortic dissection. With aortic dissection, you come across a pain that's sudden in onset, tearing, sharp, and radiating to back. There might be difference in the pulse of the two arms. Think of aortic dissection. Next, myocardial infarction. Get an EKG. Look for any ST elevations MI. Hypertension is the most common cause. And mind if I tell you this is an end organ damage. Why? Decreased blood supply, chest pain. Look for acute myocardial infarction. Look for any aneurysm. Shortness of breath, diastolic dysfunction. Acute diastolic dysfunction can lead to shortness of breath and pulmonary edema. With hypertension, there are chances of acute MI, and then that can lead to pulmonary edema and shortness of breath. This is a very, very important point, red flag. Back pain. With back pain, especially interscapular regions, think of aortic dissection. Think of aneurysm. With lower back pain, think of abdominal aortic problems. This can present to you with tearing sort of pain. Syncope, again, can be a sign of stroke. With hypertension, increased chances of cerebrovascular accidents. Cardiac accidents can lead to syncope. blackout, visual changes, retinopathy, optic nerve damage, increased retinal pressure, vitreous hemorrhages. These can occur with increased blood pressure. Retinopathy, or there might be a decrease in visual field. Pregnancy. This is very important again. With hypertension, increase in more than 140, increase in 20 millimeter of mercury in pregnant, but a systolic and diastolic of more than 90, 10 of 90. Think of eclampsia and preeclampsia. You have to manage the patient with eclampsia and preeclampsia. If not, urgent cesarean section has to be done. This might lose the fetus. So pregnancy is a red flag sign with hypertension or with hypertensive emergency. Seizures. Patient with increased blood pressure can present to you with cerebrovascular accidents and seizures. Intracranial cerebral intracranial bleed can present to you with seizures, and that is due to increased blood pressure. Chronic or ischemic stroke before with multiple chronic hypertension can present to you with scar epilepsy or seizure-like activity. Antihypertensive medication. Some drugs cause reflex hypertension when they're suddenly or abruptly stopped. They can cause hypertensive emergency problems. So again, while you work in emergency department, first and the foremost thing you have to understand and you need to realize life-threatening and limb-threatening problems. Forget about what might be the pathophysiology or what can be the diagnosis. While working in emergency, you have to realize, you have to understand the red flags, the warning signs, patient coming to you with hypertensive emergency. There can be, again, headache with CNS problems, headache with neck problems, chest pain, acute MI, aortic dissection, shortness of breath, back pain, syncopal attacks, visual changes, pregnancy, eclampsia, preeclampsia, seizures, or antihypertensive drugs. So what should be the main target of blood pressure control in hypertensive emergency? It's 25% of mean arterial pressure in first 30 to 60 minutes. So moving on, once you realize the patient is stable, the red flags are not there, not present, or in short, the patient is hypertensive urgency, take on a history. Are there any symptoms? And if there are any symptoms, onset. Was there any abrupt symptoms? Duration of the presenting symptoms. For example, if a patient comes to you with headache, and he says, I have been mild headache before in the past 3 days, but now it's the worst headache of my life. I don't know. I never had this episode before. So what should be your first diagnosis? That's intracranial bleed. There can be intracranial bleed. Patient comes to you with headache, sudden onset, pain in the neck. Think of vertebral artery problems. Patient comes to you with chest pain, sudden onset, profuse sweating, history of chronic hypertension. Think of MI. Think of aortic dissection. Because hypertension is the most important cause of aortic dissection as well. So onset of the symptoms and duration of the symptoms are very, very important. Any consumption of unusual foods prior to onset of symptoms. This is an important point. Does the patient have any severe headache? Why is this headache so much emphasized? Headache at times can be mild, at times can be worse. It can present with photophobia, can present with loss of consciousness, seizures, fit-like activity, blindness at times. So why is the headache so much important? If a patient comes to you and just say, this is the worst pain I ever had, and the pain score I would give is 10 or out of 10, think of intracranial bleed. Any speech, gait abnormalities, focal, sensory, motor deficit, or mental changes. Why is this so much important? Yes, think of stroke in patient with these deficits. At times, the patient is apparently fine. This patient can have a posterior cerebral stroke with gait changes. So if a patient comes to you with hypertensive emergency or have increased blood pressure, and he or she tells you, I have a problem in my right arm or in the left arm or any part of the body, there is a weakness in my body, a specific part of my body, think of a stroke. Ask the patient if there is any slurring of the speech. Talk to the patient. Ask the caretakers around him. Ask for any motor deficit or sensory deficit. Can the patient feel accurately or not? Any changes in mental capacity or mental thinking, or any mental changes, any behavioral changes in the recent past? A red flag sign as well. Any complaints of abdominal or back pain? If there is abdominal pain out of the proportion, think of mesenteric ischemia. Think of abdominal aortic aneurysm. Any back pain, especially thoracic spine, interscapular regions, aortic dissection, very, very important diagnosis. Any visual disturbances, as I mentioned before in the red flag signs, any visual disturbances, there is increased chances of optic nerve damage and retinopathy with chronic hypertension and acute hypertension as well. So you have to ask the patient, is there any vision loss? Or is there changes in the vision in the past few days or few hours when the symptoms started off? And what was the blood pressure at that time when the symptoms started? So, moving on to physical examination. It is often difficult for an emergency physician to examine a patient with hypertensive emergency. But it is very, very important to look for symptoms and particular end organ damage. With physical examination, it can help you make the diagnosis of a patient. Is the patient having acute changes or the patient is having a chronic problem? So, first, vital signs. What do you check for vital signs? Blood pressure. More than systolic of 130, a diastolic of 130 is hypertensive emergency with end organ failure. You have to check for pressure difference in the two arms. More than 20 there is a vascular injury going on. So, vascular abnormalities. Next, autonomic instability. How do you check? You check in 3 positions: prone, upright sitting, and upright standing. With gravida uterus, you ask the patient to lie down in left lateral position. Why? Because when the patient is lying straight, there is increased pressure on the inferior vena cava because of the uterus. This helps in a false reading of a blood pressure in a patient with pregnancy. Tachypneic or hypoxic patient with the signs of hypoxia. This can help this can be diagnosed in vital signs. Fundoscopic eye examination. Vascular changes. What are the vascular changes? Well, that can occur in acute hypertensive emergency, hemorrhagic exudates. While on the other hand, silver wiring or AV nicking is a chronic changes in chronic eye changes in chronic hypertension. Papilledema, macular changes. These are signs of acute hypertensive emergency leading to retinopathy and eye problems. Hemorrhagic and exudates. Examine optic disc for papilledema. Very, very important sign of acute hypertensive emergency. Acute and chronic hypertensive changes. As I mentioned before, with chronic hypertensive changes, you have AV malformation or AV nicking. There might be hemorrhagic exudates. Silver wiring is a sign of a chronic hypertension. Next is neurological. Check for alertness, awareness, and normal functioning. Look for signs of cerebral hypoperfusion. Is the patient talking fine? There is no difference in the speech or slurring of the speech. Is the patient conscious? Is the patient understandable or can understand what you're saying? Can repeat what you're saying? If the gait is normal, there is no neurological deficit. There is no behavioral changes. Changes in mental status, focal abnormalities, any signs of focal neurology, any motor or sensory abnormalities or weakness. So moving on to physical examination, cardiovascular examination. It's a very, very important examination. Pulse abnormalities. When you find there is diminished pulse may be present or there is a pulse difference, think of coarctation of aorta or aortic dissection. Heart failure, diminished pulses, coarctation of aorta or aortic dissection. Tachycardia, gallop rhythm, that S3 rhythm. Distended JVD, signs of left heart failure. These are the very important examination points when you see a patient with hypertensive emergencies or with cardiac problems. That is end organ damage, that's or chest pain or any shortness of breath the patient present to you with, an ED, and have a history of hypertensive emergency. These are the important physical examination points that you have to understand and you have to remember while examining a patient in emergency department. Peripheral edema, signs of pulmonary, signs of left heart failure as well. Now moving on to pulmonary, left heart failure, pulmonary rales, bronchi and wheezing. Sometimes in cardiac asthma, it occurs in cardiac asthma, but most of the time it is due to left heart failure. With skin, poor peripheral perfusion, signs of chronic hypertension, stigmata of chronic hypertension. So before going further, you have to understand this physical examination at times could be hard for a physician or emergency physician in ED present in patients with hypertensive emergency. So first and the foremost thing, we have to ask the patient if there are any symptoms, and if there are, have to examine the relative organ or system associated with that complaint. So again, hypertensive emergency is patient with symptoms. Without symptoms is hypertensive urgency. So differential diagnosis. First is acute coronary syndrome. So how would a patient present to you? Chest pain, radiation to back or radiation to the left arm, associated with nausea, vomiting, and apprehension. Central chest pain. What will you do? ECG first. Check vitals, check for airway breathing and circulation, then comes an EKG. Won't take much of your time, but give you enough information. ECG is very important. EKG would give you if there is any ST elevation MI or non-ST elevation MI. Or is there any ischemic heart disease going on? And what lab investigations to be done? Blood complete picture, basic metabolic profile, cardiac markers, and chest x-ray. This can help you to the diagnosis. Acute pulmonary edema, again a sign or a complication of acute hypertensive emergency, or acute hypertensive emergency plus patient with previous ischemic heart disease and now presenting with pulmonary edema. So what investigations? Blood BNP levels, CBC, basic metabolic profile, cardiac markers, and a chest X-ray. Acute renal failure, decreased urine output can be a sign of acute hypertensive emergency, causing end organ failure or end organ problem to renal system. What to do? Blood complete count, metabolic profile, renal function test, and at times can be required as radiological studies for renal artery stenosis. Aortic dissection, sudden chest pain radiating to back or tearing kind of pain in the interscapular regions. There might be difference in the pulse. Think of aortic dissection. What to do? Complete blood count, CT chest, might need a surgical review in this patient. Hypertensive encephalopathy. Patient present to you with altered mental status. Subarachnoid hemorrhage. So what to do? Blood complete picture, CT scan, or lumbar puncture if CT scan is negative. Drug use, drug overdose. There are many drugs which can increase blood pressure. So what to do? Patient can present to you with chest pain, altered mental status, chest or any other symptoms. What to do? Complete blood count, tox screen is important in these patients. Intracerebral hemorrhage, intracranial bleed. Intracerebral hemorrhage is very, very important and a worse complication of acute hypertensive emergency. So what to do? What can a patient present with? Altered mental status, headache, worst headache, CT scan, neurosurgical review, medication withdrawal, reflex hypertension. Reflex hypertension can present to you with multiple or vague symptoms. Pheochromocytomas, preeclampsia and eclampsia in pregnancy. How to treat? Antihypertensive, and if in severe cases, might need magnesium replacement. Subarachnoid hemorrhage, again, can present to you with neck stiffness, altered mental status. So how to diagnose? CT scan or lumbar puncture if the CT scan is negative. So moving on to diagnostic testing. First, ECG, a very, very important bedside investigation, especially patients who are with acute hypertensive emergency and present to you with acute chest pain. First and the foremost thing you have to realize is myocardial infarction. ECG within no time it's not hard to get an ECG within no time, but it can give you a lot of information. It's easy, accessible, and within minutes you can diagnose a patient with chest pain if this patient is having an ST elevation MI, non-ST elevation MI, or any other cardiac abnormalities. Next would be radiological studies, which includes first the chest X-ray. Chest X-ray is very, very important, especially in the patients who present to you with acute pulmonary edema. Acute pulmonary edema due to left heart failure. Increase in the size of heart. Cardiomegaly can be seen with chest X-ray. Next would be brain CT scan. Brain CT scan is very, very important in the patients who present to you with altered mental status, any neurological deficit, subarachnoid hemorrhage, vomiting, excessive vomiting, any signs of focal neurology or sensory or motor deficit. CT scan is very, very important. Any signs of intracranial bleed will be demonstrated on the plain CT scan, on a brain's plain CT scan. Next will be lab investigations, complete blood count, signs of anemia. Look for hematocrit or white count cells. Basic metabolic panel. It's very, very important, especially in the patients who are supposed to be or who are prone to get end organ renal damage due to chronic hypertension or acute hypertensive emergency. How would a patient present to you? Decreased oral intake, dizziness, decreased oral intake, dizziness, and decreased urinary output. So renal function test in this basic metabolic profile could tell you they might be having any renal vascular injury. Next is urine analysis. Then pregnancy tests, especially patients presenting to you with acute hypertensive emergency, and you think of either history or you think of a pregnancy, get a pregnancy test because it can help you identify eclampsia and preeclampsia. These are life-threatening diseases for the fetus, and you have to control the pressure in the patients who are pregnant and with eclampsia or preeclampsia. Tox screen, patients who are with drug overdose can present to you with acute hypertensive emergency. So tox screen is very, very important in these patients. So moving on to treatment. First is labetalol and esmolol. These are very highly used drugs in recent times in emergency. With labetalol, the initial dose is 20 milligram IV and can be given from 20 to 80 milligram. Next is esmolol. Esmolol loading dose is 250 to 500 mcg per kg per minute, and can be within maintenance dose of 50 mcg per kg per minute. Nicardipine starts with the infusion rate at 5 milligram per hour, and the side effects and the contraindication in the patients with allergic reaction or patient with aortic stenosis or patients who are allergic to calcium channel blockers. Next is hydralazine. Hydralazine is most importantly used in patients in pregnant females or with the diagnosis of eclampsia and preeclampsia. The dose is 5 to 20 milligram IV Q 4 to 6 hourly. Next is phenoldopam. Phenoldopam is with continuous infusion dose of 0.1 to 1.6 mcg per kg per minute. Nitroprusside is another treatment drug in treating acute hypertensive emergencies, and nitroglycerines. These decrease the preload and afterload and can be started at an infusion rate of 5 to 10 mcg per minute and can be increased or decreased according to the blood pressure. But again, there are a wide variety of drugs that can be used in emergency department for the treatment of acute hypertensive emergency. But what should be the target? The target should be 25% of decrease in 25% of mean arterial pressure in patients with acute hypertensive emergency within 30 to 60 minutes. A rapid reduction in blood pressure can lead to cerebral hypoperfusion and eventually can lead to cerebral vascular accidents. So special patients, as I mentioned before, pregnant, females with eclampsia and preeclampsia, hydralazine is a drug of choice. This can be given to the patient, to pregnant females. Pediatric population most commonly is due to secondary hypertension. They have a renal vascular injury or renal artery stenosis, or have any organic cause in the pediatric population. Stroke, again, patient present to you with acute hypertensive emergency and there is a cerebral vascular accident or intracranial hemorrhage. You have to lower the blood pressure to 25% of mean arterial pressure. Do not go for an hypoperfusion. With rapid reduction, there are chances of hypoperfusion and cerebral vascular accidents. So in special patients, especially in pregnant females, you think of eclampsia and preeclampsia. Control of blood pressure is very, very important. How do you do that? Hydralazine is a drug of choice in patients who are pregnant and pregnant females. For preeclampsia or eclampsia, magnesium can also be given in the worst case. In pediatric population, think of a secondary cause. So how do you diagnose hypertension in pediatric population? Increase in blood pressure, but increase in blood pressure 95th percentile of that age is considered hypertension. Stroke again is a cerebrovascular accident, can be due to acute hypertensive emergency. So what are the myths? Emergent treatment for elevated blood pressure. At times, the patient is anxious. The patient is in pain. This can cause tachycardia. With tachycardia, there is increased chances of high blood pressure. But that doesn't mean this patient needs treatment for high blood pressure. Patient needs treatment what causing the tachycardia or symptoms. That's anxiety or pain or some other things that is not related to hypertension. Do not treat hypertension in that patient. Treat the cause. Look for acute end organ damage and treat the acute end organ damage. Patients of hypertension. It's important to treat the patient, not the number. Treat the symptoms first, not the number. Patient present to you with hypertensive emergency with end organ failure, forget about the numbers. Treat the patient. Patient with involving ischemic stroke, urgent lowering of blood pressure should be avoided. Why? Again, cerebral hypoperfusion. With cerebral hypoperfusion, increased chances of cerebrovascular accidents. So continuing myths, patients with asymptomatic hypertension can be managed in outpatient department. Patients with hypertension and heart failure, fluid overload should be treated first. Patients who are pregnant, patients with acute hypertensive emergency, patients who are pregnant, they have a lower threshold as compared to non-pregnant females. So the eclampsia and preeclampsia that are more life-threatening, and we see this complication in patients with pregnancy and eclampsia and preeclampsia. So in this lecture, we started off with what is hypertension, what are the two types of hypertension, which includes primary hypertension and secondary hypertension. Primary hypertension itself is called essential hypertensive without any obvious cause. With secondary hypertension, there are some causes. Then we differentiated between hypertensive emergency and hypertensive urgency. With hypertensive urgency, there is increase in diastolic blood pressure of more than 130, but there is no end organ damage or asymptomatic increase in blood pressure. While on the other hand, hypertensive emergency is increase in blood pressure with end organ damage or with symptoms. Then we talked about some red flags of acute hypertensive emergency that includes CNS involvement, acute MIs, aortic dissections, some vascular abnormalities, some eye abnormalities, some renal system abnormalities, and abdominal vasculature abnormalities. For as a physician in emergency department, you have to look for red flag signs because at times they're life-threatening or limb-threatening. Then we talk about the history of a patient presenting to you with acute hypertensive emergency. Then we talk about some examinations to be done, which includes the visual examination. Then we move on to some physical signs, for example, cerebral examination, CNS examination, neurological examination, cardiac examination, pulmonary examination, chest examination. These are important examinations to be done. Then we talk about some differential diagnosis. What are the differential diagnoses which can be a cause of chronic or acute hypertension? Then we talk about the drugs that can be used in a patient with acute hypertensive emergency. But again, the take-home point is, again, with increase in acute and blood pressure should be reduced just up to 25% of mean arterial pressure. By doing more than that, there's increased chances of cerebral hypoperfusion. Then we talk about, at the end, some myths in dealing with acute hypertension. That's all for now. Thank you for watching.